Just give me a second. Hope I'm audible. Okay, great. Hey guys, welcome back. Good evening. This is Dr. Ranjith here. So I thought that today we will have a quick discussion on RBC image and inclusion bodies, right? So if you take hematology as such, it's one of the important topics, be it your FMGE exam, NEET exam, or INICET exam. And quite a few things in RBC disorders are image based, be it your target cell, be it an spherocyte, be it an sickle cell, many things are image based. So if you have any images regarding RBC, I think this video, it will be a very short 20-30 minute video. That will be a one-stop solution for you to discuss, understand, and maybe if it comes in exam, you'll definitely write the right answer, right? So let's go ahead. With that note, we'll go and see a few classical images regarding RBC disorders. This is the first image. Whenever I use the image, I will add a few more little bit important high yielding information regarding the image sideways, so that it will be quick revision for you before the exam, right? This is a bone marrow biopsy. If you can look, how to identify first bone marrow biopsy is the question. If you look at this, you can see the pink color structure, right? You can see this pink color structure. Okay, just give me a second. If you see the pink color structure, that is your bone marrow trabeculae, fine. The entire thing is in bone marrow biopsy here. So this pink color structure here is called bone marrow trabeculae. So if you take a bone marrow, be it in a long bone or a soft bone or a flat bone, it's completely made of bony spaces. In between the spaces, we have the bone marrow space, right? So these bony trabeculae are the bones, the cortical bones. And in between this entire space here, maybe I'll highlight in red color, this entire thing is in bone marrow space. This is where your hematopoiesis happens, right? This is where normally hematopoiesis happens, in between the trabecular spaces, fine? Perfect. Now, if you look at this bone marrow space, what color are you seeing? Predominantly, you're seeing clear spaces, right? It's clear in appearance. You don't see an RBC. You don't see much of blue dots. It's predominantly clear in appearance, right? Clear means, we know what does clear mean. Clear means it's going to be predominantly made of fat. So here, by interpretation, this bone marrow biopsy has fat-filled bone marrow spaces. That's what our interpretation is with this image, right? It's nothing but a fat-filled bone marrow space. So when I have a fat-filled bone marrow space, what is your first thought? If you remember, while reading physiology or even the starting of hematology, you must have read about red marrow and fatty marrow or yellow marrow, right? So which is functional? Obviously, red marrow is functional, yellow marrow is non-functional. Non-functional marrow, or in you and me, adults, your long bones will have yellow marrow because it's not functional, right? So these are actually the non-functional marrow. When I have fat-filled spaces, it's a non-functional marrow. If it's non-functional bone marrow, and if I say this bone marrow biopsy is from the pelvis of an adult, can I say it's diagnostic of an aplastic anemia? Yes, absolutely. That's how you diagnosed aplastic anemia. It's a classical case of aplastic anemia where I have an fat-filled bone marrow space, right? So that's diagnostic. If it's completely filled with by fat, and if I'm going to put a needle and I'm going to aspirate it, will I have anything? Will I have RBC, WBC, or platelets coming out in the aspirate? We won't have, right? Nothing will come. That's why in case of an aplastic anemia, that also is an MCQ. Bone marrow aspirate will have something called a dry tap, right? Will have something called a dry tap. That's diagnostic of it. Bone marrow aspirate will have a dry tap. That's also diagnostic of an aplastic anemia, right? This is in short about aplastic anemia. Now, second thing, when do I call it aplastic anemia? Is there any diagnostic criteria? Like, for example, let's say I have hematopoietic element here in this violet color structure. Will I call it aplastic anemia? Is there any criteria for me? Like, okay, this many amount of spaces should be fat filled. This many should be hematopoietic to call it aplastic anemia. Yes, you do have a criteria. The criteria is a very, very simple criteria. When you have bone marrow cellularity of less than 25%, this is a very superficial criteria. This should be enough for an undergraduate level. If my bone marrow is less than 25% cellular, that's one of the criteria which I can tick the boxes for diagnosing of an aplastic anemia. I do have severe, very severe and subtypes. Like I said, that for undergraduate, we need not know in depth of about classification. Less than 25%, I'm going to call it a severe case of an aplastic and diagnostic of an aplastic anemia, right? That's one thing which I want to know. This is a biopsy of an aplastic anemia, fat-filled spaces. Dry tap is an MCQ. Aplastic anemia predominant causes idiopathic, where you have an stem cell is being destroyed by an autoimmune process, so it's not able to produce RBC, WBC, and platelets. Fine. Okay. What is this? The spotter. What are these? I'm sure everyone here will know the answer. You'll jump to the answer, right? That's perfect. Target cells. Target cells are easy to pick up. I'm sure everyone who's going to sit in the exam will pick up target cells. So if I am the examiner, I have to make it a little bit difficult, right? I use the term codocytes. Codocytes are also called as target cells. Codocytes actually means bell. Target cells are supposed to be bell-shaped cells. When you look at the electron microscopy, see, this is a two-dimensional structure, right? That's why I have a dot in the center. When you look at electron microscopy, what happens exactly in target cells in a three-dimensional structure is a target cell looks like this, a dome-shaped cell. This is how a target cell exactly looks. It's an irregular cell, that's all. So that's why I have your hemoglobin here, I have hemoglobin here, I have hemoglobin here. When you look from the top in a microscopy, then it looks like a target cell, right? That's how a target cell looks. It's a dome-shaped thing, a bell-shaped thing. Codo means a bell. It looks like a bell, right? A bell-shaped structure is called as target cells. That's why it has other name codocytes, right? Can anyone comment which is the first disease which comes to your mind when you see target cells? Any disease which comes to your mind? Any disease which comes to your mind? Thalassemia is one thing which I want you to remember. Anyone, if you see target cells, first possibility, I want you to think of thalassemia. Sickle cell anemia is the next thing which I want you to remember. And in severe case of iron deficiency anemia, you can see target cells. The reason why we have a target cell is it's a broken or a damaged membrane. Thalassemia will damage the membrane, obviously. Sickle cell anemia, you have the clumped hemoglobin sickle, right? Hemoglobin S. It will also damage the membrane. Sickle can also have, that can also have. In extreme case of iron deficiency anemia, my bone marrow blasts are not that normal. They also might have a damaged poikilocyte, which can give rise to target cell, right? So target cells, other name is codocytes. And these are the three possibilities in the descending order I want you to think when you see target cells in a periplasmia. First, obviously thalassemia, right? Next, what are these? I'll just underline, maybe circle them or mark them. What are these cells? They're very classical cells. What are these? Normal, abnormal. They're definitely abnormal, right? So if you look at this RBC, they are like this. They are irregular. I would say the projections in most of the RBCs here, which I've underlined, are irregular projections. Let me zoom. They're not sharp projections. They are blunt projections, right? They are blunt and they are irregular, right? So when you have an RBC with an irregular and blunt projections, right? Irregular and blunt projections, you think of something called an acanthocyte. Okay? You think of something called an acanthocyte. Acanthocyte is an RBC with an irregular and a blunt projection. It also has one more name called a spur cell. Do remember this. I'll tell you how to remember spur cell. The name spur became because if you have seen any old English movies, cowboy movies, the cowboys will have a ring in the foot that's used to kick the horses for running. That is blunt and irregular wheel-like thing, right? That's called as a spur. So this RBC looks like the wheel in the cowboy's foot, so it's called a spur cell or an acanthocyte. So when do you see a spur cell is, first of all, it's a normal RBC. We have to understand why it is becoming irregular. If I understand that, I can easily enumerate the causes or etiology where you see the acanthocyte or a spur cell. When I have an RBC membrane, if it's becoming irregular, my major problem is in the membrane. What's any membrane made of? Phospholipid bilayer, right? So this RBC membrane also is made of phospholipid bilayer only. So when I don't have, or when I have a problem in the synthesis of phospholipids or any error in the lipid metabolism, the membrane is not going to be proper and it becomes irregular and it becomes projectile and wavy, right? So causes of your acanthocyte or a spur cell, first thing, the organ which metabolizes fat, which organ is that? Liver, right? So the first thing is liver metabolizes fat. So in case of a liver failure, what's going to happen is there'll be a reduced amount of fat metabolism or an abnormal fat metabolism. So there's an abnormal fat metabolism. Automatically, I'm going to have an abnormal membrane constituents which is not able to hold the perfect biconcave shape. It projects here and there. That's all, right? Then I'm sure most of you must have come across a second thing because that was asked once in MCQ. I'm putting it second and I want you to think the last. The first thing when you see an acanthocyte, it's obviously liver failure. If at all, if this option is there, go for it. A beta lipoproteinemia. It's an A beta lipoproteinemia. Again, it's A is absent beta lipoprotein. So how do we differentiate liver failure induced acanthocyte and A beta lipoproteinemia induced acanthocyte? Microscopy wise, I cannot. Clinically, I can. Right? A beta lipoproteinemia. There's a problem in the absorption of beta lipoprotein from there's a problem in the intestine, in the enterocytes. I'm not absorbing the beta lipoprotein properly, so it's not going into my liver. When it's not going to the liver, beta lipoprotein, it cannot be there in your RBC membrane, right? So here, there are few things which is characteristic. You will have a history of malabsorption. Malabsorption induced diarrhea will be in the history. That will not be seen in liver failure, obviously. And if you see the microscopy of the intestine, in the intestine also you'll have an abnormal fat accumulation. It's not being absorbed into the bloodstream, but from the food it comes into the epithelium. From the epithelium it doesn't come into my bloodstream, so all the fat will get accumulated in the epithelium, right? So you have an abnormal epithelial deposit. Okay, we have an abnormal epithelial deposit, we call it an case of an A beta lipoproteinemia. It's fat. Abnormal epithelial deposit is nothing but fat. What's the color of fat? It's just no, so it'll be clear. When you see clear fat vacuoles on the epithelium of an intestine with malabsorption and acanthocyte, you call it an A beta lipoproteinemia, right? I just want to add one more because these two are the things are commonly being discussed in multiple places. So if it repeats, I'm sure you will write it, right? Add one more thing. There's a disease called as an neuroacanthocytosis. Okay, so it's not actually related. So I have a neurological deficit in a condition which also has peripheral smear acanthocytosis. That's why I call it a neuroacanthocytosis, right? So, and one thing called as a McLeod phenotype. There are multiple minor blood groups, right? So McLeod phenotype is something which will have acanthocytes on peripheral smear, like Duffy, Kell, and Anderson. We have a phenotype called as McLeod phenotype, and the McLeod phenotype makes my RBC membrane weak, which has the appearance of an acanthocyte. And this McLeod phenotype can be associated with a neurological symptom. That's where I call them neuroacanthocytosis, right? There's a common finding. Again, these two are already known. Just an extra information. Think if at all, if you don't find any of these options, look for McLeod phenotype and neuroacanthocytosis, fine? We'll go to the next image. It's a very classical image here, right? If you look at this image, we saw in the last image, there were projections and they were irregular. If you look at this image, I do have projections, but they are regular, right? They have perfectly regular, and again, these are blunt projections. They're not sharp projections, right? They are obviously blunt projections. This regular and blunt projection, I use the term echinocyte. It's also called as bursal. Echino, that means sea urchin, like a sea porcupine, right? So it looks like projections all around the RBC, so which looks like a sea urchin, so it's called an echinocyte, right? Or a bursal. Bursal is a common finding. I want you to remember two things in bursal. If you see in any patients in future bursal, if it's not, it's just an isolated finding in a corner. Ignore them. It can be artifactual. But if you look in this smear, I have like maybe some 10 20 RBCs here. 2, 3, 4, 5, 6, 7, 8, 9. Quite a few of them has the regular and blunt projections, right? If it is pathological and not artifactual, it will not be seen occasionally, it will be seen everywhere, right? So one thing please important, if you are going to read a report in future, echinocytes, if they are occasional echinocytes are artifactual findings. Okay, it's not important for us, they are artifactual findings, right? It's completely fine. But when I see echinocytes which are completely seen throughout, surrounding and uniform, I wanted to think of uremia or CKD. That's only finding chronic kidney disease where I will see echinocytes in almost like every second or third RBC will have this projections. It's diagnostic, it's pathological. If it is occasional in the corner seen, artifactual, please ignore that, fine? Okay, that's about one more RBC morphological change, right? So I'm sure everyone will answer. Actually, there are multiple findings here. We'll go one by one finding. The first one, which is classically seen for us, is these guys. Sickle, right? What is this? Target cell. We have target cell. I'm sure you can appreciate the target. So it's a faint one, but yes, it's definitely a target cell. We do have sickle cells, and maybe I'll just take this cell. If you look at this cell, It's smaller compared to most of the RBCs seen. Yes, will you accept? Yes. It's a bit darker as well compared to most of the RBCs. They don't have a central parallel. So in this image, actually I'm having three cells. One is spherocyte, one is target cell, and the other one is sickle cell. But how do you identify spherocyte? This is actually a spherocyte. Spherocytes are easy to identify, and I want you to remember spherocyte and know everything about spherocyte, not a superficial understanding. Because when you have a superficial understanding of spherocyte, there's very high chance you might end up in doing an error, right? So the way to identify spherocytes, they are smaller RBC, they are darker RBC, and they have no central pallor. Okay? They have no central pallor at all. That's how you pick up spherocyte. First and the foremost thing, the most common cause of spherocytosis is autoimmune hemolytic anemia, AIHA. Don't jump and write hereditary spherocytosis. It is absolutely rare. This is very, very common. Acquired disease is any day common than inherited hereditary spherocytosis, right? Apart from this, I want you to remember one more thing. Spherocyte is not a finding seen only in spherocytosis. It is seen in spherocytosis also, right? Apart from this, I can see them in HS, I can see them in G6PD deficiency, I can see them in sickle cell anemia, I can see them in thalassemia, or in other words, I can see them in any membrane disorder. If there is a disease which is going to affect or slightly damage the RBC membrane, the RBC becomes a sphere. How to remember is, let's assume RBC is a stretched rubber band. That's how biconcave is, right? Let's say this is what is stretching it, and I leave this finger, it becomes round. Anything subtly, slight destruction of the membrane or slight destruction of the protein which holds them to make it biconcave, it becomes spherical. That's why it's seen in spherocytosis, G6PD, sickle, thalassemia, everywhere. This is the case of sickle cell anemia, right? You still can see spherocyte, right? It's not a finding seen only in HS, can be seen in everything. How do I differentiate? HS will have classical symptom. G6PD will have bite cells. Sickle will have sickle cells. That will have abundant amount of target cells, early presentation, everything, right? So it's based on the history we will be able to differentiate. But whenever I am going to see a spherocyte, the first thing any doctor is going to think is about autoimmune hemolytic anemia. You have to rule out that first, right? Then we have a sickle cell. The sickle cell's other name, okay, I'm going to call drapano is like a boat. It's like a boat chain. Sickle cell is also called as drapanocyte, and we already know the target cell, which is an codocyte, right? Okay, next few more things. Now I'm going to go quickly run through it. And tell you an algorithm or a table to pick up RBC inclusions. Before that, I want you to know there are two stains done for RBC in peripheral smear. One is Leishman stain, one is new methylene blue stain. This is actually new methylene blue stain. NMB stands for new methylene blue. How do I pick up its new methylene blues? Look at the RBC. They are greenish blue in color, right? They are not red in color. Look at this RBC, red in color. This is an Leishman stain. I have Leishman stain where my RBC looks reddish in color, and I have new methylene blue stain where my RBC looks bluish green in color. That's how the appearance is. You have to differentiate these two. Once you differentiate these two, it's very, very simple to identify RBC inclusions. Use this flowchart. Read this flowchart the day before the exam. If it comes in exam, it will definitely be useful because there's a chance you might forget them, right? So, okay. In Leishman, if I see a single inclusion, a tiny blue dot in Leishman, I call it an oval jolly bodies. Okay, it's an oval jolly body. In Leishman, if I see multiple inclusions and I'm going to see them uniformly distributed, you call this stippled RBCs or basophilic stippling. Stippled RBC. Okay. So what do I mean by uniform and multiples? It's going to be like this. It's multiple dots throughout the RBCs. That's what I mean by uniform, right? Same in Leishman. If it is multiple, but it's not uniform, it's towards a corner. I'm just writing non-uniform. So what do I mean by non-uniform is, let's assume this is my RBC. I'll have inclusions maybe towards one corner, right? Then this, I feel it will be diagnostic of Pappenheimer body, which is seen in case of sideroblastic anemia. Okay? It's Pappenheimer body, diagnostic of sideroblastic anemia. That's one. When I take new methylene blue, I'm going to use the same thing. If it's a single inclusion, you must have heard about this Ķēhn's body, seen in case of G6PD deficiency. Yes. Multiple inclusions and uniform. I have something called an golf ball inclusion, which is seen in case of an HBH disease, right? That's how we pick them up. Golf ball inclusion seen in case of HBH disease, right? So this is how we diagnose them. If it's multiple in your new methylene blue and it's not uniform, it's a normal reticulocyte, right? This flowchart is enough. Take a screenshot of it, have it with you, read the day before the exam, just 5 minutes, and look at all the images. You will never ever make a mistake, right? Leishman or new methylene blue? New methylene blue. Single or multiple? Multiple. Uniform or not uniform? Uniform. That's your golf ball inclusion. It's very, very simple to diagnose, right? Okay. Leishman or new methylene blue? It is Leishman. Single or multiple? Multiple. Uniform or not uniform? Completely uniform. Perfect. This is basophilic stippling. So just use the flowchart. It will definitely help you to identify and completely diagnose any image which comes to an exam related to RBC inclusion, right? Leishman or new methylene blue? Leishman. Single or multiple? Multiple. And it's non-uniform. That's your Pappenheimer body. Okay, that's your Pappenheimer body. This again, it's new methylene blue. A tiny single inclusion. That's your Ķēhn's body. Right? This is Leishman. Again, a tiny single inclusion. This is your Howell-Jolly bodies. You can easily pick them up, right? So if you just follow the flowchart, this is an important flowchart. Read them the day before the exam. You will never miss any RBC inclusion which comes in the exam. But please keep in mind, don't use this flowchart for malarial parasites, because malarial parasites also will be seen inside the RBC, right? This is only for hematology related RBC inclusions, not for parasites. And don't forget to differentiate new methylene blue, where the RBCs will be bluish green in color, versus Leishman, where the RBCs will be red in color. That's very, very important for us to differentiate, right? Just before ending, there's one more additional finding here. I'm sure you can see that it's a Leishman stain, multiple uniform inclusions. In addition to that, can you see a ring inside the RBC? Yes, that's called an Cabot ring. Cabot ring is diagnostic. Again, it's an easy way to pick up. It's a ring. Generally, Cabot ring is an A-shaped structure. It can be A-shaped inside an RBC. Let's say it will be like this. Let's assume an RBC. I might have a ring like this, A-shaped, or it can be round like you see here. It's a ring seen inside the RBC where it's not been removed completely. Nuclear maturation defect. You see Cabot ring as well as you see basophilic stippling, right? So those are few RBC inclusions and images regarding RBC which I want to discuss. We just took half an hour of your time, and this will summarize almost every image where there's a probability of them to come in an exam, right? Thank you for your time. See you soon in the next video. Till then, bye bye from Dr. Ranjith. Bye bye.